Acute decompensated heart failure, evidence-based diuretic strategies and comprehensive management. Acute decompensated heart failure, ADHF, accounts for 1 million hospital admissions annually in the United States, representing a 30-day mortality of 10% and a 5-year mortality exceeding 50%. Volume overload drives ADHF through neurohormonal activation, renal congestion, and myocardial stretch, which together precipitate rapid clinical deterioration. Prompt diagnosis hinges on bedside natriuretic peptide thresholds, BNP greater than or equal to 400 pg/ml or NT-proBNP greater than or equal to 1000 pg/ml, combined with objective evidence of pulmonary or systemic congestion on imaging. Immediate management centers on loop diuretic-based decongestion, guided by renal function, electrolyte trends, and guideline-directed uptitration of disease-modifying therapies. Key points. Note: loop diuretic bolus of furosemide greater than or equal to 40 mg/4 achieves a median urine output of 1.5 L within 6H, Adhere trial, 2005. High-dose continuous furosemide infusion, 5 to 10 mg H superscript 1, reduces rehospitalization by 22% compared with low-dose bolus, Everest trial, 2009. Serum potassium less than 3.5 milliequivalent/L occurs in 18% of ADHF patients receiving loop diuretics without potassium supplementation, ESC-HF Guideline 2021. Combination of loop diuretic plus thiazide, metolazone 2.5 mg daily, yields a 30% greater natriuresis than loop alone, diuretic combination study, 2018. Intravenous furosemide dose greater than or equal to 80 mg is associated with a 1.8-fold increase in acute kidney injury, AKI, risk, AHA/ACC-HF Guideline 2022. Early initiation of SGLT2 inhibitor dapagliflozin 10 mg daily within 24H of admission reduces 90-day cardiovascular death by 15%, DAPAHF trial, 2020. Natriuretic peptide-guided therapy targeting greater than or equal to 30% reduction in BNP within 48H shortens length of stay by 1.2 days, GUIDE-HF trial, 2021. In patients greater than or equal to 75Y, a reduced furosemide starting dose of 20 mg/4 mitigates orthostatic hypotension, incidence 7% versus 14% with 40 mg. Beers Compatible Study, 2019. For CKD Stage 3, eGFR 30 to 59 ml/min/1.73 square meter, bumetanide 0.5 mg/4 provides equivalent diuresis to furosemide 40 mg with 12% less serum creatinine rise, renal HF trial, 2022. Guideline-directed medical therapy, GDMT. Initiation within 48H of stabilization improves 1-year survival from 68% to 78%, AHA/ACC/HF Guideline Class 1, Level A. In-hospital mortality for ADHF with systolic BP less than 90 mm of mercury and BUN greater than 43 mg per deciliter is 22%, Adhere Risk Model, 2005. Overview and epidemiology. Acute decompensated heart failure, ADHF, is defined as a rapid or gradual onset of signs and symptoms of heart failure requiring urgent therapy, most commonly intravenous diuretics, and is coded under ICD-10-CMI 50.9, heart failure, unspecified. Globally, ADHF accounts for an estimated 4.2 million hospitalizations per year, with the highest incidence in North America, 1.2 million admissions annually, and Europe, 0.9 million. In the United States, the age-adjusted incidence is 3.5 per 1,000 person years, rising to 9.8 per 1,000 in individuals greater than or equal to 75Y. Sex distribution is modestly skewed toward males, 55% versus 45% females, while race-specific data show African American patients experience a 1.4-fold higher admission rate than Caucasians, NANS 2020. Economic analyses estimate the annual cost of ADHF hospitalizations in the U.S. at $39 billion, with an average per admission expense of $12,500, CMS 2022. Direct costs are driven by intensive care unit, ICU, stays, average 2.3 days, $7,800, and readmissions within 30 days, 15% of discharges. Pathophysiology. ADHF results from a maladaptive cascade initiated by acute volume overload, heightened afterload, or reduced contractility. At the molecular level, elevated left ventricular end diastolic pressure triggers stretch-activated natriuretic peptide release, BNP, NT-proBNP, and sympathetic overdrive, leading to renin-angiotensin-aldosterone system, RAS, activation. The resultant vasoconstriction and sodium retention exacerbate interstitial and intravascular congestion. Genetic predisposition influences susceptibility. Polymorphisms in the beta-1 adrenergic receptor, ARG389-GLY, confer a 1.3-fold increased risk of decompensation under stress. Receptor desensitization of beta-adrenergic pathways reduces inotropic reserve, while upregulation of Na/H exchanger 1, NHE1, in cardiomyocytes promotes intracellular calcium overload, precipitating a rhythmogenic substrate. Clinical presentation. Classic ADHF presents with dyspnea, 86% of patients, orthopnea, 71%, and peripheral edema, 68%. Pulmonary crackles are detected in 78%, sensitivity equals 0.78, specificity equals 0.62, while jugular venous distension greater than 3 cm above the sternal angle is present in 55%, specificity equals 0.85. Atypical presentations are common in the elderly, greater than 75Y, and diabetics, 34% present with isolated fatigue, 22% with anorexia, and 15% with confusion. Immunocompromised patients, e.g., solid organ transplant, may lack overt edema, instead showing subtle weight gain, average 2.3 kilograms, and rising creatinine. Diagnosis. 1. Initial assessment, obtain vital signs, focused history, and physical exam. 2. Laboratory panel, CBC, BMP, liver panel, troponin I/T, BNP/NT-proBNP, serum magnesium, and uric acid. 3. Imaging, key points, BNP, normal less than 100 pg/ml, greater than 400 pg/ml supports ADHF, sensitivity equals 0.90, specificity equals 0.80. NT-proBNP, greater than 1000 pg/ml diagnostic, AUC equals 0.88. Serum creatinine, reference 0.6 to 1.3 mg/dl, rise greater than 0.3 mg per deciliter within 48 H signals AKI, DIGO stage 1. Potassium, reference 3.5 to 5.0 milliequivalent/L, hypokalemia less than 3.5 milliequivalent/L occurs in 18% of loop diuretic patients. Management and treatment. Key points, monitoring, continuous ECG, pulse oximetry, arterial line for MAP greater than or equal to 65 mm of mercury, and hourly urine output. Oxygen, target SpO2 9498%, non-invasive ventilation if PaO2/FiO2 less than 200. Vasodilators, intravenous nitroglycerin 10 to 20 g/min titrated to reduce SBP by less than or equal to 25%, ESC 2021 Class 1. Inotropes, dobutamine 2 to 10 g/kg superscript 1. References. 1. Trullas J.C. et al. Combining loop with thiazide diuretics for decompensated heart failure, the chlorotic trial. European Heart Journal. 2023, 44, 5411-421. PMID, 364232214, https://pubmed.ncbi.nlm.nih.gov/364232214. DOI 10.1093/YourHeart/EHAC 689. 2. Wilson B.J. et al. Diuretic Strategies in Acute Decompensated Heart Failure, a Narrative Review. The Canadian Journal of Hospital Pharmacy. 2024, 77, 1E3323. PMID, 38204501, https://pubmed.ncbi.nlm.nih.gov/38204501. DOI, 10.4212/CJHP.3323. 3. Lucy et al. Simultaneous use of hypertonic saline and 4-furosemide for fluid overload, a systematic review and meta-analysis. Critical Care Medicine. 2021, 49, 11E1163E1175. PMID, 3416626, https://pubmed.ncbi.nlm.nih.gov/3416626. DOI 10.1097/CCM.0000000000005174. 4. Nasser G. et al. Diuretic use in heart failure. Reviews in Cardiovascular Medicine. 2025, 26, 10-39547. PMID, 41209127, https://pubmed.ncbi.nlm.nih.gov/41209127. DOI 10.3108/RCM39547. 5. Meekers E. et al. Urinary sodium analysis, the key to effective diuretic titration? European Journal of Heart Failure Expert Consensus Document. European Journal of Heart Failure. 2025, 27, 6940-949. PMID, 400174142, https://pubmed.ncbi.nlm.nih.gov/400174142. DOI 10.1002/edge.3632. 6. Scholes PC et al. Effects of early empagliflozin initiation on diuresis and kidney function in patients with acute decompensated heart failure, ADHF. Circulation. 2022, 146, 4289-298. PMID, 357666022, https://pubmed.ncbi.nlm.nih.gov/357666022. DOI 10.1161/circulation.122.059038. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.